and commonly associated with rheumatoid arthritis and infectious etiology consists of RP. In patients with associated systemic condition, the underlying disease is already known in about 80% of patients at the time of scolitis presents. 15% of patients were diagnosed with a new systemic condition as a result of initial evaluation, and among patients with non-underlying inflammatory condition, it is important to exclude of an infectious complication of immunosuppressive therapy. So what is the workup of the patient with scolitis? Evaluation of patient with scolitis consists of clinical evaluation, laboratory investigation, and imaging modalities. Clinical evaluation includes history, a specific question regarding systemic disease common in scolitis, eye examination in diffuse light and slit lamp examination, and also systemic examination. Baseline investigation include hemoglobin, CBC, ESR, complete metabolic profile, and X-ray chest. Laboratory studies based on the clinical finding, that is a lot of the investigation that order only to the particular investigation with the systemic disease. Coming to the imaging studies, radiography, chest radiography, sinus film, sacroiliac radiography, and limb joint radiography, that based on the systemic finding. Ultrasonography, CT scan, and MRI for the posterior scleritis, and new evaluation of the anterior segment OCT in diagnosis of anterior scleritis and the follow-up for the treatment. Here, the anterior segment OCT present the nodular anterior scleritis that show the nodules in subepioscleral tissue with fluid in the subepiosclera and scleral inflammation. After treatment, resolution of the nodule, and after completion of the treatment, complete resolution of scleral edema and nodule. Other tests includes smear cultures and PCR from conjunctival, corneal, epioscleral, or scleral scraping in case of infectious scleritis, and PCR of body fluids in infectious scleritis. Coming to the treatment, the medical management, the aim is treat the cause, relieve the inflammation, reduce the damage, and complete systemic control. Drugs include NSAID, corticosteroid, and immunomodulator. In diffuse anterior scleritis, the initial therapy is NSAID. That is fluorobiphrin, indomethacin, and selective COS inhibitor. The second line is oral corticosteroid at a dose of 1 milligram per kg of body weight. Remission may be maintained with continued NSAIDs. Third line is the periorbital and subconjunctival steroid injection, that is injection triamcinolone acetonide 4 milligram per ml, not indicated in necrotizing type of the scleritis. Fourth is the immunomodulator drug, that is methotrexate, azathioprine, cyclophosphamide, and cyclosporine. In case of necrotizing scleritis, cyclophosphamide 100 milligram per day orally and tapered monthly is the first choice. In treating patient with associated potentially lethal vasculitic disease. Second, the initial therapy consists of immunosuppressive drugs that are supplemented with corticosteroid during the first month and later is tapered slowly. Third is the pulse intravenous cyclophosphamide with or without pulse intravenous corticosteroid may be required in case of emergency, followed by maintenance therapy. Treatment of infectious scleritis, systemic treatment is the main treatment with or without topical antimicrobial treatment. The algorithm of the scleritis therapy, the first line is the NSAID. If therapeutic failure, then go for the systemic steroid. If remission occur, then maintenance on the NSAID. And if case of therapeutic failure, even after systemic steroid, go for the immunosuppressive drugs. Thank you.
Thank you, Dr. Srikanth, for taking this neglected topic and giving a very comprehensive presentation. Anybody if want to know anything extra, please. In that case, I invite Dr. Now I invite Dr. Sunil Verma to come for his topic on laser peripheral eye.me. Sunil Verma has done his MBBS and MS both from KGMU. He has done his fellowship in anterior segment and now is a consultant in Raj Eye Hospital.
Good evening, everyone. My topic of presentation is laser peripheral iridotomy. Laser peripheral iridotomy attempts to open a